Hello everyone, and welcome back to another episode of Discussions with Dr. G, where I somehow make the delightful world of coronary artery disease, or CAD, sound like your favorite TV dramedy. I'm Dr. G, and before I lose your attention to TikTok, let's break down what's actually going on in these rebellious little coronary arteries. So picture this. Coronary arteries are like little city highways delivering oxygen to your heart muscle, and atherosclerosis. Is the original traffic jam. It basically is a cholesterol-laden plaque gunking up your arteries. You've got this greasy cholesterol lipid mess slowly narrowing the arteries over time. And as the road gets smaller, there's not enough oxygen-rich blood getting through. Heart muscle doesn't get what it wants, and enter angina. Now, angina is this ischemic chest pain that pops up when oxygen demand is higher than supply. Three main flavors here: stable, unstable, and the ever dramatic variant, also called Prinzmetal angina. Stable angina shows up with exertion or stress, and it walks away if you rest or pop some nitroglycerin. Unstable angina, though, does not play nice. It comes at rest or out of nowhere, and frankly, it's just the drama queen of chest pain. Higher risk for MI, which we'll get to. Now, variant angina, it's like the moody artist of the group, caused by coronary vasospasm, not by plaque. I'm telling you, back in my night shift days, I tried to explain this stuff to a brand new intern. She looked at me like I was reciting Shakespeare in Klingon. She's holding her coffee cup, staring at me, and I'm like, no, listen. Stable is predictable chest pain. Unstable is like when your ex keeps texting you in the middle of the night, unexpected and always a bad sign. Variant is when your text app spazzes out for no reason. That's vasospasm and not blockage. Yeah, she still switched to pediatrics. Anyway, moving right along. So what if you don't catch that ischemia early? Well, that's when you hit the myocardial infarction zone. Prolonged lack of oxygen and the heart muscle cells start to die off. Goodbye, viable myocardium. What follows is remodeling, decreased cardiac function, not the stuff you want to see. Plus, you've got the additional complications: dysrhythmias, heart failure, shock, recurrent ischemia. The heart just can't seem to catch a break. And that, in a nutshell, my friends, is why understanding the root of CAD is so key before we even start to dive into the meds. So, let's jump into what everyone actually wants to know. What do I give, when do I give it, and how do I keep my patient from bottoming out onto the floor? Medications are how we become the traffic cops for this bad situation. First up, nitrates, nitroglycerin, the OG chest pain fixer. Works fast, releases nitric oxide, relaxes all that smooth muscle, and basically acts like a decongestant for arteries. Boom. More blood flow, less heart stress. Sublingual nitro is your first responder for acute angina. Also, it's used for preventing heart attacks. Now, please remember, do not give nitrates if the patient's already hypotensive or, recently used any recreational PDE5 inhibitors like sildenafil. Trust me, mixing those is an instant call rapid response. We teach our patients to use nitrate-free periods to avoid tolerance and, that classic nitro headache. Completely normal. They'll hate it, but they need to know it. Acute scenario, 3 doses, 5 minutes apart. If it's not resolved, call 911 faster than you can say STEMI. All right. Beta blockers are next, and these slow the heart, reduce workload, and are fantastic post-MI. Think MA for metoprolol atenolol, or think that cardioselectives start with the letters A through M. Non-selective start with N through Z, with the exception of carvedilol and labetalol. You can remember those because their endings are not OLOL. It's ILOL and ALOL. That's important because when you get to a patient with asthma, you've got to watch out and make sure that the cardioselective ones have been prescribed, or else you can very well trigger a bronchospasm. Also, teach your patient not to stop them suddenly, otherwise they risk all sorts of nasty rebound issues. Calcium channel blockers. amlodipine for those who need vasodilation, diltiazem and verapamil for rate control. These are great for stable and variant angina, and especially if beta blockers aren't tolerated. But, as always, don't use certain types if your patient's got heart failure. And please keep an eye out for peripheral edema and bradycardia. Let's throw in ACE inhibitors like lisinopril or ARBs like losartan, especially post-MI or for those with diabetes and kidney disease. They help prevent cardiac remodeling and lower afterload. Common issues: cough, especially with ACEs, hyperkalemia, and don't even think of administering these to your pregnant patients. Then you've got ranolazine as an adjunct for folks with resistant angina. It doesn't drop the heart rate or the blood pressure much, which is a blessing if your patient can't handle those drops. But you do have to watch out for QT prolongation. ECG, ECG, ECG. Now, on to the blood thinners. Antiplatelets like aspirin or clopidogrel to keep those stents patent and prevent clots. Standard of care is aspirin plus a P2Y12 inhibitor like clopidogrel for at least a year after MI. But the bleeding risk is real, guys. You've got to educate your clients to report weird bruises or black stools. Anticoagulants are on another level. Heparin, warfarin, DOACs, and you need to be on the lab patrol with these. APTT, INR, and don't forget BASH. That's bleeding, abnormal platelets, surgery, and hypertension. Thrombolytics like Alteplase, those are reserved for STEMIs if PCI isn't available. But they are so incredibly risky. Seriously, you're doing neurochecks every 15 minutes because bleeding is no joke. These are absolutely contraindicated for patients with active intracranial hemorrhage, have had an ischemic stroke within the last 3 months, have had recent major surgery or trauma within the last 2 weeks, if they're pregnant, if they have an arteriovenous malformation, any kind of known bleeding, or uncontrolled hypertension. Now, we're also seeing some new players. Statins for lipid lowering and plaque stabilization. PCSK9 inhibitors for hardcore LDL drops, and even omega-3s. These are all useful, but each have their own quirks, like statin-induced muscle pain. Omega-3s make you burp fish oil for weeks. Let me bring this to life with a case. Mr. Trinidad, my favorite fictitious patient, comes to the ER with chest pain. We slam on the nitrates, and he nearly stands up. Whoa! Sit down, sir. Hypotension incoming. Next morning, he's bradycardic on his first beta blocker, so we cut the dose. 3 days later, he notices muscle aches. Yep, that's statin myopathy. The point? You got to be ready to monitor, reassess, and not just set it and forget it. Meds are not on autopilot. Now here's where nurse brain really shines. Safety and judgment. On recognizing those sneaky cues, patients with chest pain, you're doing that OPQRST assessment. You know, onset, pain, quality, radiation, severity, and time assessment. Maybe you spot ST changes on the ECG, or your patient suddenly looks pale or confused. It's all about connecting the dots. For any unstable angina or suspected MI, we go to MONA. Morphine, oxygen, if needed, nitrates, and aspirin. It's not served on a silver platter, but trust me, the patient will appreciate it more than brunch. When you give these meds, you're checking, double checking, and sometimes triple checking for contraindications, especially like with nitrates mixing with ED drugs. That's erectile dysfunction. That's sildenafil I talked about earlier. Or a hypotensive patient that's about to get vasodilators. Education is big. Teach your patient to always sit down when taking nitro, warn them about those headaches, and urge them to call EMS if the pain's not gone after 3 sublingual tabs in 15 minutes. Beta blockers, teach them to check their pulse before every single dose, and whatever they do, don't just quit cold turkey because they ran out. Statins, you're telling these guys to take them at night, right? Speak up if they get muscle pain. bleeding precautions for antiplatelets and anticoagulants. No, seriously, if you want to see blood in your stool, don't ignore it. And maybe hold off on the new kickboxing class. I always laugh when I think about my favorite frequent flyer, Mr. R, who looks at every new pill and would say, "Doc, is this one going to make me feel funky?" He was convinced every med was some sort of psychedelic. Kept me on my toes with my teaching game. And honestly, it should be like that with every patient. Make sure that they're not anxious, skeptical, or wanting clear answers. And if they do, give them the clear answers. Our job is education, monitoring, and making sure that what we give is actually working. Are they pain-free? Can they walk farther? Are their labs stable? If not, start troubleshooting. So as you go out there ready to tackle CAD, just remember, it's not about memorizing the drugs. It's about integrating assessment, safety, and education every time. You're never just passing pills. You're making actual life or death decisions. And don't worry, there's plenty more medication trauma where this came from. So you're going to catch me on the next episode, right? Cool. Until then, keep saving hearts, and don't forget to always check your patient before your phone.